welcome to the Psychiatry and Psychotherapy podcast. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. One thing that created a lot of burnout and angst for me was trying to get continued medical education right at the last minute. So why not join the CME membership and do CME while listening to this podcast? Go to psychiatrypodcast.com, sign up, sign in, take the test, and the certification is emailed to you in seconds. Welcome back to the podcast. I am joined today with Jonathan Shedler. He's a Ph.D., internationally known author, lecturer, consultant, master clinician. He wrote a pivotal paper called The Efficacy of Psychodynamic Psychotherapy. And he also is the creator of the Shedler-Weston assessment procedure for personality diagnosis and clinical case formulation. He is constantly writing and tweeting, and he's prolific on Twitter. And I was thinking, if you ever tweet this episode, people could comment, and then maybe we could use some of those comments in a subsequent episode. So if you're listening to this, go check out Jonathan Shedler on Twitter. That's Jonathan Shedler, Shedler. Before we start, do you have any conflicts of interest to disclose?
I don't.
Okay. Neither do I.
I'm one of those rare people in the mental health professions who's not, who's not on the payroll of some industry.
Oh yeah, they have been trying to entice me, and I have so far declined.
I'm sure.
So I wanted to start with one tweet that you put out. It's actually your pinned tweet. Could we look at this together and?
Sure.
Kind of, because I think it's, there's something about this, especially in our moment, right? Okay, here it goes. One of the most important things I've learned: severe personality problems find camouflage. No one thinks I'm a sadist or I'm a malignant narcissist. They find a belief system, social group that validates their most hateful, destructive impulses and construes them as virtues. The most toxic, hateful people in the world are 100% convinced they fight for what is true and right. They find a way to give free rein to their cruelty, to attack, to treat others cruelly and viciously. And they find allies to cheer them on, who also believe they're on the side of all that is true and good. For colleagues looking for more of a theoretical explanation, the psychological processes are splitting, projection, and projective identification. Splitting means not recognizing one's own capacity for hate, cruelty, and destructiveness. The person is blind to the bad in themselves. Instead, they project the badness onto some designated other. And this is the other person. Via the defense, projection is now seen as a repository of all that is bad and evil and necessary to destroy. That's the projection. The person now feels fully justified in unleashing their viciousness and hate on the other person, who is now seen via projection as someone monstrous who must be destroyed. If the person who is projected on responds with provocation, with anger, and this is now seen as further confirmation of how hateful and destructive they are. This is what is called projective identification. The end result is that the person can deny their own sadism, cruelty, and hate while simultaneously acting it out without further restraint, and feel themselves to be 100% on the side of truth and right as they do it.
Quite a bit packed into there, isn't there?
Do you want to tell me about this tweet?
Where would you like me to start? I mean, the big picture is people have the mistaken sense that psychoanalytic or psychodynamic theory and therapy is something, mysterious or obscure or arcane. And in fact, it deals with the phenomena of everyday life. The things that we deal with are all around us and inside of all of us. There's nothing rare or esoteric or unusual about it. I mean, we have a way of understanding things about the life of the mind, about human connection and interaction. And it really applies everywhere. It's not, it's not just applicable to a certain kind of therapy for a certain kind of person. It's applicable to psychotherapy in general, and it's applicable to life in general.
Yeah. Yeah, I was thinking about this, and I was thinking, now this was a tweet that was in 2021, September 24th. So it's a while ago, right? And so we're like, as you were listening to this, you were probably thinking he tweeted this out more recently, right?
It's kind of evergreen, isn't it?
Yeah, you could,
because okay. So you asked me to talk about it. So people, we deal with this all the time. First of all, let me just give you a little background about this issue of camouflage. I learned this very, very early in my career. I was a brand new graduate student. I was 20 something, in my early 20s, and I was in a clinical placement, and I just had the opportunity to shadow a psychiatrist for a while and sit in on his interviews with patients. And there was one that stuck out and really made an impression on me. And we were trying to decide, I say we, I was just a student, but the psychiatrist was trying to decide, was this person psychotic? Were they delusional? And, sitting in the interview, what we got from the patient was that he spoke to God and God spoke to him. And, and I watched this psychiatrist try in every way he knew how to try to, clarify, what does the patient really mean by spoke to God? Is he literally hearing a voice that he experiences as coming from outside? Is he hearing auditory, hallucinations? Or, is he speaking, in a way that's kind of culturally normative within his church, within his subculture? And the thing that really grabbed me was I couldn't tell. And I didn't know whether the psychiatrist could tell or not. But then I later wrote his report. And he basically said in the report, well, the patient may be having auditory hallucinations, or he might be part of a Christian community where this is normative. And he just flat out said, I can't tell. And what I took away from that was an insight that applies far beyond psychosis. It really applies to any kind of any kind of mental health disturbance. That disturbance finds camouflage. Right? We find some community that seems to normalize and validate, the thing that's most dysfunctional, right? And that it applies across the board. And we can see this playing out just in life every day, right? So. You had a guest a few weeks ago, Dr. Rob Feinstein, who edited a book about personality disorders, and I wrote one of the chapters in the book, and he was talking about borderline personality disorder. And for a lot of people, a lot of the time, it's much preferable to find camouflage where the characteristics or the symptoms of borderline personality disorder are normalized and validated. We see that in our culture all the time. So what does that mean if you're a clinician, or what does this mean if you're just a person going about your life? You suddenly find yourself the target, the object of intense, vicious hatred by somebody who doesn't even know you. Right? They're a stranger to you. How did I suddenly get to be so important to this person? How is it that this other person is treating me like somebody they know intimately? They know everything about me. How is it that they seem to know my thoughts, my motives, and intentions, but in fact, I'm a stranger to them? Well, this is where the psychoanalytic concept of projection comes in. And the idea is, good and bad are hypothetical constructs, right? It's people are not good or bad. People have the capacity to be very good in some ways and very bad in other ways. And that's true for every human being. It's the nature of the human condition. And a psychologically healthier or more mature psychology recognizes these contradictory impulses in ourselves, the desire to take care of others, to help, to be compassionate, to be kind, the desire to harm others, to inflict pain, to damage and destroy, right? We recognize this. And ideally, these conflicting impulses or, desires that we have by virtue of being human are kind of integrated so that, so that the totality of all of the desires tends to keep the most extreme ones in check, and we recognize them as part of ourselves. As we get into the range of personality pathology, that capacity isn't there. We tend to be aware of certain states or feelings or desires in ourselves, and the negative ones, the hateful, destructive ones, get projected onto other people. Or it doesn't even have to be a person. It can be, an institution or, a concept. But, the bad, the capacity for bad is not in me. It's out there, right? That's the projection. Projective identification takes the projection a step further. Projective identification means I can now unleash all my hatred without restraint on that other person or that other thing that seems to be the embodiment of all that's evil, right? And I can treat the other person so absolutely badly. I can treat them so horribly that, that they react to it and they become angry or they become enraged in turn. So in a way, I've made the projection become true. And that's what the tweet is about.
Yeah. So I think the way that I understand projective identification is that because you are projecting this stuff into the other person eventually can identify and become a little bit different than they normally would be. And I think we can all, as therapists, learn that this happens to us as well. Like if we start to become a little bit different towards a patient that we normally wouldn't, we normally wouldn't act out, or we normally wouldn't want to maybe cross a boundary or collude in some way with a patient. And so when that's happening, are we identifying with a projection, right?
Yeah,
Is that what you're talking
there's
about?
There's a wonderful phrase that always stuck in my mind. I don't know who said it originally, but I know I read it. It's in one of Glenn Gabbard's books. And he talks about the experience, the clinicians in therapy will describe the experience as like having their mind colonized by something alien. Right? It's not subtle. It's actually pretty extreme, where the clinician catches themselves thinking things, feeling things, reacting in ways that are really out of character for them. They're just like, this is not who I am. This is not how I think or feel or function with them when I'm with patients. And all of a sudden, right, it's like my mind has been colonized by something else to the extent, to such an extent that it's hard to think your own thoughts or feel your own feelings, right? It's extreme and it's dramatic, and it happens in psychotherapy all the time. And the work on the part of the therapist is, number one, can I recognize that this is what's going on? Can I recognize that something has pulled or pushed, or provoked me into responding in a way that's really quite different from how I would normally respond to things? Can I recognize it? And then, having recognized it, can I find my way back to thinking my own thoughts and my own feelings, and then be able to make use of what happened in the interaction constructively, right? As a way to gain some insight and help the patient gain some insight into, number one, what's going on internally in their own mind and their own emotional life, and number two, how this plays out interpersonally in relationships with other people. Of course, I wrote the tweet on social media. So somebody somewhere said, Twitter is the world's biggest and longest running experiment in projective identification, because it's just going on left and right, all the time. And unlike in therapy, what you can't do on social media is do what therapists do all the time, just basically say, well, wait a minute, let's slow down and think about what's happening here between the two of us. Right? Social media doesn't allow for that.
Right. It's I think one aspect that I want to zoom in on of this tweet, which I think is like really important, which if this episode becomes about this tweet, that would be hilarious. But this idea of how with prolonged therapy, you become more aware of your shadow, the kind of the dark impulses, and the shame is reduced enough so that you can look at them, but then not react to them in the same way maybe that you would if you couldn't see them clearly. If it's like unconscious, you'll react, and in the reaction, you can potentially have these more darker impulses become destructive.
Yeah, I mean, everybody has destructive impulses. It's not even psychologically interesting to say it. I mean, it's just a fact that there's not a human alive, or at least I should say, there's not a human alive who's meaningfully in touch with their inner life. Who doesn't some of the time have revenge fantasies? Have fantasies about hurting someone, have fantasies about murdering someone. I mean, the issue is that, for most people, most of the time, they remain in the realm of fantasies. Fantasies are free, right? So we can accept them as a part of ourselves. We understand this is part of what it means to be human. There's nothing shameful about it, right? But there's a very clear distinction. Ideally, in a healthier person functioning in a healthy way, there's a clear distinction between fantasy versus action. Right. And as you get into more serious kinds of personality disturbance, right, the boundaries between fantasy and action start to get very murky. Right. Mm-hmm. And, you get people, I mean, this is really the essence of projection and projective identification. You get people who can't recognize their own capacity for hate and repeatedly see it somewhere else outside of them. And then if they proceed to act on that perception, right, and, actually act destructively toward the other person, then you have a pretty big problem. And, you could argue that society as a whole right now is kind of slipping toward, toward a more primitive mode of psychological functioning societally.
Yeah. And I think, of course we are, because prolonged stress, isolation, fear of the future, like everyone is experiencing that more than usual, right? So of course we're all stressed out. Of course we're all booked out and slightly burned out. If you're a mental health professional at this point and you're feeling great, you've come through the last couple of years and, that's great. That's wonderful. But a lot of us are very tired, right? A lot of us are kind of a little bit more.
But I think there's something else going on, and I think it partly has to do with. The internet. The instant accessibility to tens or hundreds or thousands or millions of people.
Yep.
with a keystroke. I think it has something to do with social media. One of the roles of society has always been. What makes a civilization is that society exercises some control, some restraints on our most destructive impulses. And now, absolutely anybody, with a couple of mouse clicks, can find, a subculture that's going to support them and cheer them on. Find the most hateful person and, fill in the blank, the thing that the hate is directed toward. And, there's an online community that will affirm, validate, and cheer on the person's most, destructive and hateful impulses. And I think I think there's something new happening in the culture. It's not that it's never happened before. There have been, there have been historical catastrophes. There's been war. There's been genocide. But I think what's different now is the average person, anywhere, sitting in their bedroom or their parents' basement, can plug in mm-hmm. to the sort of wellspring of hatred. Right? Yeah. Anyone, anywhere, anytime.
Yeah.
And be told, be affirmed and supported and reinforced for giving themselves, be reinforced in the behavioral sense, right? For giving themselves over to their most hateful impulses.
attention, especially with attention increasing. There was that recent sort of, thing with Facebook that came out where, they knew that some of their stuff was leading to bad outcomes, but they kind of like tried to hide it up. And in a previous episode I actually looked at all of the research that they used to present that social media is good. And actually that's not true, right? Especially after you get around like 3 hours or 4 hours, it's like all mental well-being starts to decline. If you're doing it like if you're doing it beyond somewhere around like an hour, it starts to kind of like, that's where like the decline starts to happen. So I do think that it preceded COVID. I mean, there was an increase in suicidality in adolescence, especially in the previous decade, right? And a lot of this is new. It's a new experiment that we're all going through. It's not a great experiment. Wow. Well, this is a good time for psychotherapy, right? And so when I was reading your article about how long psychotherapy takes,
Mm-hmm.
and I think that we all could sort of hear this and really mow over, like, there's something about the APA coming out with that statement that you kind of wrote about how, like, there's this ideal of 10 sessions or something. Did they stand by that, or were they behind that? The American
Well, there's two
Psychological
APAs, but in this right, there's the American Psychological Association, the American Psychiatric Association. But in this case, they seem to be pretty aligned. And I mean, what's going on is this: there's just such a bifurcation, such a division between what academic researchers are doing and the clinical reality on the ground. And we're making clinical practice recommendations based on just bizarrely artificial studies coming out with sort of just bizarrely unhelpful recommendations about how to treat people. And here's what's going on. It's incredibly difficult. It's methodologically complex. It's resource intensive. It costs a tremendous amount of money to study psychotherapy in the context of a research trial. And what that means is researchers have just declared, it's not a scientific finding. It was an assumption they made before they ever did any research. They've just declared we're going to study 8-session or 12-session or at the most 16-session therapies. And so we have all this research literature, hundreds and hundreds of studies on just say treating depression alone, and they're all based on on treatments of less than 16 sessions. And it's not, maybe I'm repeating myself, but it's really important. It's not a scientific finding that you can treat people effectively in 16 sessions or 12 sessions. That was an assumption the researchers made before they began the study, before they collected any data. And so now what people are saying is, well, it's evidence-based. These therapies are evidence-based because research has been done. Well, yeah, there's a lot less research being done on therapies of meaningful duration, right? Because it's incredibly difficult to do that. But I mean, think of the absurdity of this. If you have a study that looks at a certain kind of therapy and it's 12 sessions, and there's some evidence that it would be effective, how does it make sense to say, well, the 12-session version of the therapy is effective, but if we were to extend that longer, to 20 sessions or 40 sessions, that's not scientifically validated. That can't be part of the treatment guidelines. It just doesn't really make sense. So the question becomes, and then there's this sleight of hand, right, where people say it's evidence-based because research was done. But when they say evidence, when the researchers say evidence, and when they talk to journalists and journalists write about evidence, and it filters down into college undergraduate textbooks, right? What they mean by evidence is that there's a group difference, in a randomized research trial, and the group that got whatever treatment of interest, the group that got the treatment overall, on average, did somewhat better, usually not much, than a control group that got no treatment or got a sham treatment. And we say the treatment was effective, the treatment works. But then but that's not a question that's relevant to clinicians or to patients. If you drill down, and the question becomes, okay, there's a group difference, but do people who get the treatment get well? And the answer that comes from scientific studies is absolutely crystal clear. The same research that people cite to say brief CBT, 8 or 12 sessions of CBT is effective. The very, very same studies show that the overwhelming majority of people who get these treatments don't get well and don't stay well. Right? So there's a bit of a sleight of hand going on in how we present and disseminate research, both in the mental health professions and to the public at large.
Yeah, and so I think the hypothesis, if I can summarize kind of what I think your big points are here, is that number one, longer psychotherapy works better than short-term psychotherapy.
Well, it's not a hypothesis. It's an empirical fact. Right? So sorry to interrupt. This is just so important.
It's good.
There's 3 ways of doing studies, right? So what the researchers who are studying so-called evidence-based therapy are not doing is starting with the question, how long does therapy realistically take, for a meaningful number of people to get meaningful benefits? The research is just not asking that question. There's a whole other body of research that does ask that question, and there's 3 ways to do it. I mean, you can ask patients who have had therapy, who've had effective therapy, how long did it take before the therapy started to have meaningful benefits? You can ask clinicians the same question. Turns out you get surprisingly similar answers from patients and clinicians. Or you can actually track patients in over the course of time. Right? You could administer standardized outcome measures at intervals throughout the therapy and ask the question, how long does the therapy take before, say, 50% of the patients, show some clinically meaningful level of improvement? And, we know the answers to that. I mean, treatment benefits, right? On average, everyone is different, but on average, clinically meaningful benefits begin at around the 6-month mark and continue for 1 to 2 years afterward, depending on the person. So these studies of evidence-based therapies that are the basis for APA, both APAs, practice guidelines, right? All of these studies are of therapies that are over right before meaningful clinical benefits even begin.
Yep. And just to kind of summarize this, your pivotal article that you did for the audience who maybe haven't read it, and if you want to read it, I'll link it on this the show notes and in the
Sure.
article that I'm going to write on this. But the basic cases that you make is that therapy is effective largely. It doesn't matter if you're doing CBT or psychodynamic therapy. Like all therapy is effective to some degree, and it seems that the things that make longer term therapy successful have more psychodynamic foundations, meaning a focus on emotion, a focus on the relationship between you and the client.
Yeah, and those are empirical findings too. And there's really we talk about the science practice schism. There's much less of a schism between practicing therapists, CBT therapists or psychodynamic therapists. I mean, real therapists operating in the real world understand that therapy takes time. People don't come packaged with, single DSM disorder categories, right? People are complex. We need to create a relationship with the patient, right, over time, right? So therapists understand that the actual schism is between practicing clinicians and researchers who operate, kind of in parallel universes.
Yep.
But to address your specific question, in studies of CBT, manualized CBT conducted, in the studies I'm thinking of, according to Aaron Beck's cognitive therapy treatment manual, it turns out it's not actually the specific cognitive interventions in the manual that account for outcome. It turns out it has to do with things like the quality of the relationship, right, between the therapist and the patient. It has to do with recognizing defensive processes as they arise in the therapy, and it has to do with using the therapy relationship itself as a window into the kinds of relationship patterns and problems that show up in other places in the person's life, right? Those are actually empirical findings. So when people say this brand of therapy is effective, this brand, that brand, the story is actually far more complicated, because the active ingredients in actual treatments are not necessarily what researchers and practice guidelines are spinning them to be.
Right. But you tweeted out that you wish you had kind of invented your own brand of therapy, because then you'd probably be much more wealthy at this point, And I think I tweeted back at you, yeah, but I think I would respect you. I respect you more because of the stance you've taken. And
I remember that. Yeah. That was a few days. And let me unpack that a bit for listeners. There's certain fundamental principles of human psychology that that are at the heart of all therapy approaches that are effective. And there's really no incentive in the research world to publish about that, make that case, study that, right? The incentive is to invent something new, or at least something that you can claim is new, right? Brand it, right? Turn it into a 3 or 4 letter acronym. And there's, hundreds of them. And then you go and promote your therapy as if you've discovered something, completely new and different. And yet it turns out again and again and again, the active ingredients are fundamental principles of human psychology that are incorporated to a greater or lesser extent in the acronym therapy. So, I kind of take a dim view of this proliferation of acronyms and selling therapies like brands, when the truth of the matter is, right, they become commodities. But the truth of the matter is that the one thing that's central to therapy being effective, all kinds of therapy being effective, the thing that's central is the kind of relationship that the clinician and the patient are able to form. And that can't be turned into a commodity.
Right.
You can't commodify, a human attachment.
Right. A real relationship.
Correct.
And it takes time. I mean, it's going to be, you can do fine. You can make a good living being a therapist. You're never going to be super wealthy. You just aren't.
Unless you start a cottage industry around a therapy brand name, and then you can make money from selling courses and workshops and seminars and books and then you're not making money by being a therapist. You're making money by selling a brand, which is really something quite different.
Yeah. I remember when I went to I went to a big psychotherapy conference. I won't say the name, but I think day 3, it dawned on me what every person was doing there was they would give just enough to tantalize your appetite to wow, this person has something of value, and I'm insecure because I'm a new therapist, so I really need something of value. And then, they promote their workshop, which is kind of where they make their money, And so, I nothing against people who do that. I think you can take away a lot from some of these workshops. I've been to some of them. But at the same time, what we're talking about is there's common factors which you can, which are more basic and also very hard to, it's hard to do without actually practicing, doing it, and receiving supervision, and then actually being in therapy yourself.
Those are the pillars of it, right? So I actually believe there's such a thing as a master clinician. All right, you have to have a certain aptitude for it, and you have to really, really work hard and for a long time to develop expertise. And I mean, you just hit the highlights of it. I mean, it takes 3 things. One is there's no substitute for experience. You really have to, spend your hours treating patients, doing the work. It's a version of the 10,000 hour rule. If you're not willing to spend 10,000, can argue about what the actual number is, but meaningful time doing it, you're not an expert, and you probably shouldn't be out there promoting and selling yourself as an expert, right? So you need practice experience. You need quality supervision, right? So learning psychotherapy is essentially an apprenticeship model where, you spend your time with your patients. You discuss the patients on an ongoing basis with a senior, hopefully expert colleague who can help you understand, right, what's going on psychologically and how to work with it. And the third thing is that your own personal therapy is essential, because all of the concepts that we talk about and that we use in psychotherapy, they're not concepts that apply just to patients. It's like patients aren't some, separate class of human beings, right? Psychological concepts and principles apply to people, to human beings, and they apply to us.
Mm-hmm.
And, unless we see them ourselves in our own life, unless we come to, really deeply know ourselves in our own therapy, there's a way these concepts are just sort of academic theories, right? They're not lived experience that you can actually use and apply in a meaningful way in doing therapy. We have to see it ourselves, right? So we started off talking about projection and projective identification. I mean, I think, you and I described it pretty clearly. Anyone listening would be like, yeah, that makes sense. I've seen other people do it. It changes everything when you're in your own psychotherapy and you catch yourself. Your therapist helps you to catch yourself in the middle of engaging in a projection. Yep. And the thing that's most, sort of jarring and striking and transformative about it is the realization that you were completely deaf, dumb, and blind to it until, in the context of the therapy relationship, your therapist was able to help you recognize it.
Yeah. I think I've been seeing it. It's the third therapist I've had, and I've seen her for a long time. And what's been helpful is I sometimes come to therapy thinking that what I'm about to share is shameful and going to be too much. It's like raw. It's like the thoughts that you have that you don't really want to share with anyone, and you share it anyways because it's like you have to share, like what is coming out, right? If you want to make sort of
well, you don't have to share anything, but if you want to benefit from the therapy, it's a good idea to try to.
I choose to share, and it's like because she is psychodynamically, psychoanalytically trained, it's like I don't experience judgment, and I experience curiosity and empathy and warmth, and it's surprising. The empathy and warmth are probably the most surprising things.
Yeah, and psychotherapy depends on empathy, and not empathy. The term is misused and distorted, and I mean, people say empathy, and what they really mean is coddling, sympathy, validating, affirming. That's not what empathy is. Right? Empathy is because we're more human than otherwise. Right? In a sense, there's nothing in the realm of human emotional experience that is completely alien to any of us. Right? Empathy is the therapist's capacity to, feel and understand, not understand cognitively, intellectually, but feel, because they can recognize it in themselves, to feel something of what your experience is like. Right? And then, of course, it's not about judging or shaming or scolding, right? When it's in the context of recognizing all of these things are in the realm of human experience. Right? Now, how can we understand them? How can we make use of that understanding in ways that could make your life easier or better or richer?
Yep. Yeah. Okay. In normal day practice, here's one thing that gets in the way of empathy. It's envy. And I'm curious how you've experienced this with your success. Like, do you ever share a success with someone, and the first thing that you initially see on their face is like a flash of anger, and then maybe like some contemptuous or it doesn't even need to be contemptuous. It could be just like kind of like, oh, I wish I had, or like there's a a close line between envy and admiration. I'd be curious, like, what your thoughts are on, like,
I'm imagining you get a certain amount of that because of the success of your podcast.
at times, yeah, or other, yeah. And I'm curious, like, it takes away sometimes my enthusiasm if I'm enthusiastic about something, and then it's like if I experience envy as kind of like the initial response, I notice it now, and
Yeah.
I kind of I think I can have empathy for their envy sometimes, or
And think
desire.
about we started by talking about projection. So think about how it would make a world of difference if you were somebody with the capacity, or somebody who had worked to develop the capacity to recognize that envy in yourself, to not say, no, that's not me. I'm not that kind of person. To recognize, I wish that was me. I'm a little resentful that this other person is having these successes and I'm not. There's a part of me that would like to take them down a notch and put myself up a notch. I think of the world of difference it would make if you have the capacity to recognize that in yourself, see it in the mix of all of the other, nuanced and complex feelings that you're having at the same time, right? And then, out of that awareness comes the capacity to make a choice. Am I going to act on the envy? Am I going to try to do something to diminish you? Or am I going to recognize the impulse in myself and then just say, hey, that's really cool what you've done. I'm really interested in this. I'd like to learn more about it. Maybe I'll learn something. Maybe I'll learn something from you that I don't know that might be helpful to me. Right? So, envy is always is in the mix. But if we deny it in ourselves, right? If we drive it underground, if it becomes unconscious, right, then we tend to act on it, in indirect ways that are often destructive. So, psychotherapy, or the kind of therapy you and I are talking about now, is really about knowing ourselves more fully, right? So that we can live our lives more freely, so that we can have choices about things that otherwise are sort of automatic and not a matter of choice, and ultimately, to be a better version of ourselves.
Yeah. Yeah. Do you think, okay, so you kind of mentioned to know yourself, right? And do you think that the knowing is the effective component of what makes psychotherapy work?
Ooh, that's a very complicated question. Now, I don't think it's the component, right? I mean, there's endless debate about this in the psychoanalytic world. A lot of things go on in therapy. Knowing, or insight, is one of the things that happens, but it's also inseparable from something else that's happening. Right? So our earliest relationships, our earliest formative relationships, become templates for our subsequent relationships. In one way or another, we tend to recreate these templates, these relationship patterns throughout our lives. Now we're in therapy, we're in a new relationship. And two things are happening in that relationship. One is we're making use of the relationship to pay attention and to notice and reflect on things about ourselves that we ordinarily brush aside or minimize or discount. And so that's one thing. That's the insight component. But the other thing that's happening is we are having a new and different kind of relationship. And that new relationship then becomes another template, another way that relationships can be. And, just to give a pretty crude example, I mean, people who come to therapy, people in general, human relationships are difficult. None of us get out of childhood and adolescence unscathed. I mean, everybody has the experience of, risking vulnerability, intimacy in a relationship. And, having the other person take advantage of that in some way, or having the other person use it against you in some way, right? Intimacy is difficult and scary. So a lot of people come into therapy and they've never had a genuinely intimate relationship that They've never had a genuinely intimate relationship that didn't end up hurting them in some way. Right? So they're having a new experience. I can be in a relationship. I can be vulnerable. I can unmask myself and show the sides of myself that I wouldn't normally do in the rest of my life. And, number one, nothing terrible happens. Number two, the other person doesn't take advantage of what they now know and see about me, to retaliate against me or to hurt me or to, do it back to me. The other person the therapist is interested, curious, empathic, right? So now, now I'm having an experience that for a lot of people coming into therapy and a lot of people, period, has not really been part of the realm of their experience. So one of the things that comes out of this is a whole different capacity for connection and intimacy with other people in other relationships in your life, with your partner, with your friends, with your children, with your relatives, right? Another way of being in a relationship that previously wasn't part of your templates.
Beautifully.
That goes hand in hand with understanding.
Beautifully said. Yeah, that's really good. My mentor, Dr. Tar, was taught by Franz Alexander.
Oh, wow.
And he's the one that actually introduced you to me when I was a resident. We went through your article and talked about psychodynamic therapy. And so it's really a pleasure meeting you now face to face as a someone I'm still learning from, and getting to hear from you firsthand. There's something valuable about hearing people speak, what kind of like their years of experience have given them. And so I hope my audience is grateful to have that.
Well, thank you. I'm grateful for the conversation.
That's good. Yeah. There's so much more. I feel like there's so much more we could discuss. I want to hit, is there anything else that's kind of in your mind that you want to get out to my audience, to mental health professionals today before we close up?
There's a lot. You started by talking about my paper on the efficacy of psychodynamic psychotherapy. We didn't really get into it.
I know. I want to though, and that could be frustrating, right? We could even
maybe we'll have to do another episode. I guess what I wanted to say is, there's a lot of rhetoric out there about, you hear a lot of terms. You should get evidence-based therapy. This therapy, it's always a brand with letters. This acronym, this is the gold standard. This is empirically validated. These are best practices. And of course, none of these words actually have any scientific meaning. Gold standard isn't a scientific term. It's a PR term. It's a marketing term. Anyway, I guess what I'd like to get out before we stop is there's a kind of a master narrative in the profession. And the master narrative is, there are these evidence-based therapies, and, they've been proven superior. And what's, not said explicitly, but it's always implicit. They've been proven superior to how we did therapy in the old days, meaning psychodynamic or psychoanalytic therapy. That's been debunked. It's passé. It's not scientifically supported. And there's just a yawning chasm between this narrative, the rhetoric, and the reality. Because the reality is what I demonstrated in the paper that we've been referring to, is that, first of all, the evidence that psychodynamic or psychoanalytic therapies are effective is absolutely as robust as it is for any of the therapies that are promoted, branded, marketed as evidence-based. Psychodynamic is an evidence-based therapy. But in the narrative, the term evidence-based is used as a kind of a marketing term. It's used to exclude psychodynamic therapy. But the actual scientific research shows that psychodynamic therapies are at least as effective in the short run, and apparently more effective in the long run. Right? The benefits last. So that's one thing. And the second thing is that other forms of therapy, when they're effective, are effective because of what you called common factors, right? But I would say actually the common factors are psychodynamic factors. The common factors, all of them emerged out of a psychodynamic tradition. Right? The idea of two people sitting together on a regular basis to discuss the experience of one of the people, right? With in a certain kind of, in a certain kind of therapeutic frame, right? I mean, this started in the psychoanalytic tradition. Right? So, I mean, people are getting sold a kind of a bill of goods about what makes for good therapy, and our professional organizations, both APAs, have bought into it to some extent.
Yeah, yeah, and we talk about this with your colleague who you co-wrote that book with, how there's like actually 6 therapies that work for borderline personality disorder. Although anyone on a board test would answer DBT, for depression. On a board answer, we're trained. Answer CBT. Whereas like there's just as much evidence for psychodynamic therapy. I agree that a lot of the common factors are psychodynamic factors. And I think there are a lot of different psychoanalytic theories, but I think the modern psychodynamic perspective is more in line with those core factors. And that probably begs a longer conversation on how it got to that place, right?
Well, we could start with something very basic: the quality of the relationship, meaning not to the doctor and the patient, or the therapist and the patient like each other or get along, right? A working alliance actually is much more specific. It means that there's a shared mutual understanding about the purpose of the work and the methods that we're going to use in achieving that purpose. Right? It's an alliance around a shared understanding of the job that we're here to do. So when I say the quality of the relationship, I mean it to include that. Well, if you have a psychologically healthy person who connects well with others, who has the capacity to form meaningful, positive connections with other people, then damn near anybody, right, can create a good working alliance and a good quality of relationship. But that's not the only kind of people we treat. A lot of the people we treat have, real difficulties in relating to other people, in having mutual relationships with other people, meaning relationships that work for two. And right, so now you take somebody who doesn't have the capacity to form good relationships, and they enter therapy. What happens? Well, that's where the therapist's skill and understanding comes in. And for one, you mentioned personal therapy. For one thing, you have a hell of a lot better chance of finding your way, through all of these challenges, finding your way to a way of being and connecting with this patient, if you really, really, understand yourself and, in a deep level, right? And you're not reacting to the patient's slights, the patient's attacks, the patient's ways of distancing from you, right? I mean, you think about it, what a world of difference it can make. The patient comes in and they do all of the things that tend to destroy all of their other relationships. And the therapist, instead of doing back the things that other people tend to do with them, the therapist is like noticing what's going on between the two of you, commenting on it, getting curious about why things are happening the way they are. Right? Well, those are psychoanalytic skills, whether you call them that or not.
Yeah. Yeah. That's so good. So good. It's like how do you deal magnanimously with transference from someone, when someone gets irritable at you, or like today I had a patient tell me that he had thought about torturing me, and I was more curious about it. And it was like an expression of anger and disconnection and a lack of empathy that he experienced from me. He experiences these thoughts for other people
hurt
as well.
About something.
But it largely, there was a life, there was also the transference of the life trajectory of, there was many incidents where he had felt the unempathic, a total unempathic experience from other people. And so now I was becoming just another person in this long list. But as someone psychodynamically oriented, I was able to empathize with how distressing that was for him to experience, because he didn't want to experience these thoughts. He, there was part of his experience, but not his full experience. But then also the pain of the lack of empathy. And so we were able to kind of repair the that moment of disconnection that occurred.
Yeah. So it makes a world of difference if the therapist does something that's different from what most other people, the patient, most other people we encounter in our life do when they're feeling, attacked or harshly criticized. Right. The normal human reaction is, we either withdraw and disengage, or retaliate, counterattack. I mean, it just changes everything. If the therapist response is something along the lines of, you're really angry with me. I must have failed you in some way, or I must have said something or done something that was really disappointing or hurtful. Tell me about that. It changes everything.
Yeah. Yeah. With connection, right? Connection at the end of the day, it's actually very difficult to connect with people ongoing. There's, so much of what we see day in, day out is like disconnected families, disconnected friendships, disconnected relationships, or people wanting, grasping.
Disconnections in culture and in society.
Yeah. And so it's like, it's easy reading that initial tweet